ไปนะคะจะเป็นดร. เจมส์ แม็กวิลเลียมนะคะเป็นอาจารย์ของเพียวอีกท่านหนึ่งนะคะดร. แม็กวิลเลียมนะคะจบถ้าทางด้านแพทย์นะคะจบจาก Georgetown University นะคะอยู่ที่ DC แล้วก็เป็น Clinical Assistant ที่ New York Medical College นะคะอยู่ที่นิวยอร์กเหมือนกันแล้วก็ปัจจุบันนี้12 ปีแล้วนะคะที่ท่านเป็น Medical Director อยู่ที่ Bell Wound Treatment and Hyperbaric Center แล้วก็เป็น Chief ของ Division of Foot and Ankle Surgery ที่ South Shore Medical Center นะคะ so Dr. McWilliam please
Sawadee-krap. I was originally working really hard to give my talk in Thai, and I practiced it in front of Pio, and he said, no, stick to English, and he would translate for me. So I want to thank you all for coming. I want to thank, it's really an honor for us to be here and participate in your program. I'd like to thank Dr. Tep for inviting us here and allowing us to come and participate. As I said, it's really a good honor. And I'd like to express my condolences for the loss of your king. For us, it's a different situation where, especially now with our election, where a whole country is unified behind their leader, and I think the United States could learn a lot from that. So I'm really happy. I'm both happy and sad to have been able to be a part of that experience. Right now we're going to talk about a condition that's not unique to diabetic foot and ankle surgery. It's unique to orthopedics, it's unique to podiatry, it's unique to all foot and ankle patients. And when Pio asked me to talk about this topic, I said, it doesn't really match with the overall program of diabetic foot and ankle surgery. But since being here and seeing how, with the lifestyle changes, and seeing some of the patients here who've actually been able to stop the progression of their diabetes and actually lead a more normal life, I think this is a very appropriate topic, because as you treat more patients with diabetes and they become more normal, you're going to be seeing more patients with these conditions that are thought to be treated electively with foot and ankle surgery as opposed to urgently, like the ulcers and the infections. I'm an orthopedic surgeon. The other speakers were podiatrists, and you may not know the difference. It's really a difference in school and training, but essentially the philosophies are the same, and the approaches to conditions are very similar. They're the same. There's a little bit of difference, and hopefully Pio has been able to get the best of both worlds from podiatry and training with me for 2.5 years for orthopedics. And he's been a tremendous addition to my team, and I'm certainly going to miss him when he returns here. So as I said, we're going to talk about posterior tibial tendon dysfunction in the painful adult flat foot. It's important for everybody to know that pes planus, or flat foot, doesn't describe a pathologic condition. It describes the shape of the foot. It doesn't mean there's anything wrong with your foot. It's part of the spectrum of foot shape. So you can have a very flat foot, or you could have a very high arch. And it may be present in up to 20% of the population, at least in the United States and Canada. It used to be that the military would disqualify you from service because you have flat feet. And it was a way that, I think, the way Donald Trump got out of military service. But actually he got out because of heel spurs, which is another kind of normal condition. But because during World War II, the United States and Canada were running out of military recruits, so they looked at all these, the 20% of the population with flat feet, and they realized that these were normal. So they were able to establish that flat foot isn't a condition unto itself, but it can lead to some painful conditions. This is a patient that we saw in the clinic downstairs whose flat foot isn't normal. You can see on the right here, I'm sorry, on the left, she has a much more prominent navicular. Her arch is quite flattened, and she's actually quite debilitated by this condition. You can see that she has valgus alignment of her hindfoot, or her hindfoot's very pronated, and her forefoot is abducted or moved to the outside. And you can see that because you can see her toes on the affected side. This is a painful condition for her that, luckily due to the talents of Mr. Somkiet, she's able to control this conservatively. She is a diabetic, and we talked about surgery because her diabetes is so well controlled due to the efforts here at the hospital. But the symptomatic adult flat foot can be a congenital condition, it can be developmental, It can be acquired. The most common cause that I see is insufficiency or disease of the posterior tibial tendon. So if you look at the arch of the foot, there are static supports. There's the bony anatomy, then there are ligamentous structures, and then there's the plantar fascia, which acts as a truss to help support the arch. The spring ligament is an important factor in the development of a flat foot. This is the calcaneonavicular ligament, and it can be either attenuated or frankly torn. The spring ligament acts as a hammock to support the head of the talus, so that if the spring ligament is insufficient, the talus is allowed to flex, and the patient develops a flat foot condition. Another important static support of the arch is the superficial deltoid ligament. And patients with acute trauma of the superficial deltoid ligament or acute tears of the superficial deltoid ligament can develop an acute flat foot. So now we've talked about the static supports of the foot. Then there's a dynamic support of the foot, which is the posterior tibial tendon. It's the dynamic stabilizer of the foot. So with plantar flexion and inversion of the hind foot, we turn the otherwise flexible arch into a rigid lever to allow for toe off. Unfortunately, there's an area of relative hypovascularity behind the medial malleolus where the posterior tibial tendon is prone to disease. It's prone to tearing, it's prone to tendinosis, and that can be a problem. So if the posterior tibial tendon isn't working well, then the static stabilizers can be stressed, and the static stabilizers can either stretch out or they can tear, leading to a flat foot. Now the posterior tibial tendon, if these are the axes of motion of the foot and ankle, so you have, actually I do want that, I'm sorry. So you have the axis of rotation of the subtalar joint, the axis of rotation of the ankle. The posterior tibial tendon is in the posterior medial quadrant, so it's a plantar flexor and an inverter. This hindfoot inversion leads to a situation where the talonavicular and the calcaneocuboid joints are no longer parallel, and that locks the midfoot and turns the foot into a rigid lever. So with a normally functioning posterior tibial tendon, the medial column becomes rigid, and you get efficient toe off. You get efficient transfer of force from the gastric soleus to the forefoot. In the case of a flexible flat foot or posterior tibial tendon insufficiency, the rigid lever is no longer there, and people have great difficulty with toe off. So they have a shorter stride length, decreased stride frequency, decreased single limb support time, and they have decreased plantar flexion strength. Brodsky called it an apropulsive gait. They have difficulty just with toeing off. Risk factors include a pre-existing asymptomatic flat foot, obesity, diabetes, corticosteroid exposure, and previous surgery or trauma about the foot. Patients can have an insidious onset, or they can have a history of trauma. They have a swollen flat foot that may be flatter than the opposite side. They have pain dorsally, and eventually that becomes laterally because of subfibular impingement. They have gait disturbance and early fatigue. On physical exam, you have pes planus. And from the posterior aspect of the foot, you can see there's marked hindfoot valgus on the affected foot. And then there's forefoot abductus, or lateral deviation of the forefoot. And that's called a too many toes sign. So this patient has almost all of the deformity that you could have with posterior tibial tendon insufficiency. It's important to determine whether it's a fixed or a flexible deformity. So this is the patient from upstairs. She has a very flexible deformity, because that'll dictate what type of surgery you might offer the patient if conservative measures don't work. In addition to the flexible hindfoot deformity, it's important to test the competency of their medial column. And some of these people will have medial column hypermobility, as seen here by excessive motion at the tarsal-metatarsal joint. So how do these deformities occur? If you look at this, this is like a video. This is a very simple little bony model. And you can see that if there's no support over the medial aspect of the foot, whoops. If there's no support of the medial aspect of the foot, you get arch collapse. And the arch collapse can occur anywhere from the talonavicular joint to the navicular cuneiform joint to the first tarsal-metatarsal joint. And this is really, it's a very simple model, but it really shows accurately what happens when your spring ligament, when your superficial deltoid ligament, and your posterior tibial tendon are incompetent. Now, why does this happen? It happens because of, once again, incompetency of these medial structures. And due to that incompetency of these medial structures, the calcaneus is allowed to rotate from within from underneath the talar head. So typically the sustentaculum tali, this bone right here, is supporting the talar head. But because of inadequacy of these medial soft tissues, the calcaneus externally rotates. There's no longer the support for the talar head, and the talar head's allowed to drop, just as we see here. So once again, no support here, the talar head's allowed to drop, and then the flatness extends to the navicular cuneiform joint and sometimes to the tarsometatarsal joint. Now, in addition to hindfoot valgus, you get abduction of the forefoot, or external deviation of the forefoot. So once again, no competent medial structures. If you take the flat foot to another level, you can see the forefoot abducts because the calcaneus is rotating externally and the forefoot follows the calcaneus. So you can see that here on this diagram, where in the normal situation, the forefoot is relatively parallel with the talus, but as the calcaneus externally rotates because of incompetent medial structures, the forefoot follows the calcaneus and you get forefoot abductus. Now it's important to recognize all these elements of deformity because ultimately the treatment will be based upon what type of deformity the patient has. Some patients have no deformity. Some patients just have a flat foot. Some patients have a flat foot with hindfoot valgus and forefoot abductus. So on the frontal view, you see the same thing. You can see how the forefoot's going to rotate externally as the hindfoot collapses. The last thing we see is a forefoot supination deformity because of compensation. Now the foot wants to stand like a tripod, and because of the forefoot following the hindfoot, because of hindfoot valgus, once you correct the hindfoot valgus, the forefoot is relatively supinated. And you can see that, you see that very frequently, and that forefoot supination deformity also has to be addressed. On physical exam, patients with a competent posterior tibial tendon will have hindfoot inversion, but with patients with an incompetent posterior tibial tendon, remember it's a plantar flexor and an inverter, so they may be able to step up on their tiptoes or they may not, but if they do step up on their tiptoes, they will remain in hindfoot valgus. Why does that happen? Well, there's failure of hindfoot inversion due to an incompetent posterior tibial tendon. There's altered vector of Achilles tendon pull, so the Achilles tendon actually becomes an everter, and you'll see that in the next slide. And then the midfoot is no longer a rigid lever or toe off. So here's what you'll see. So you can see this patient has significant hindfoot valgus. And you'll see this patient will have compensated and will be able to do a cingulum heroides, but his hindfoot will not invert, suggesting that his posterior tibial tendon is not competent. So he's trying to get up. With great difficulty, he's able to get up. But see, his hindfoot doesn't invert at all, so his posterior tibial tendon isn't working. Finally, these patients have a gastrocnemius contracture because of the relative proximal placement of their calcaneus because of their flat foot. So here with the knee bent, you can see the patient has good ankle motion, but with the knee extended and the hindfoot inverted, the patient will have an equinus contracture. And it's important to recognize and address that as well. On x-rays, there may be a difference in height of the foot because the arch is flat. So you can see that difference right there. On the AP x-ray, there'll be abduction of the forefoot, which is represented by an increased second metatarsal or first metatarsal angle. And then on the lateral x-ray, you'll get arch collapse, which can occur at the tailnavicular joint, the navicular cuneiform joint, or the tarsometatarsal joint, or a combination of all of the above. With weight-bearing CT scan, you can frequently see subfibular impingement or sinus tarsi impingement. You can see an open sinus tarsi there. You can see an open subfibular area there. And then in a weight-bearing CT, which is becoming increasingly available, at least in the United States, you get obliteration of the sinus tarsi and you get subfibular impingement. MRI may be helpful, but this is really a clinical diagnosis. So frequently, because of the unique nature and position of the posterior tibial tendon, there's a thing called the magic angle artifact, which will give you, it will either give you too much signal within the tendon or not enough signal. So it's not necessarily the most accurate modality. So this is truly a clinical diagnosis, and it's not uncommon for me to operate on a patient with a normal MRI who has obvious pathology on clinical examination. And here you see one of the findings is enlargement of the posterior tibial tendon and fluid within the posterior tibial tendon sheath. So treatment options are based upon the stage of deformity and the degree of deformity. Remember the 3 degrees of deformity that we talked about were hindfoot valgus, forefoot abductus, pes planus, and then you can add in the 4th degree, which is forefoot supination. If patients have a flexible deformity, then they can undergo joint sparing procedures that really reconstruct the foot and give you a more normal foot. If patients have a rigid deformity, then they'll be required to have a triple arthrodesis. And that's all based upon this classification, which was initially described by Ken Johnson in 1989, and we still use this classification with some modifications. But basically, a stage 1 deformity is stage 1 postertibial tendon dysfunction is pain along the tendon, obvious inflammation along the tendon, but the tendon functions and there's no deformity. With a stage 2 postertibial tendon insufficiency, there's a non-functioning tendon and a flexible deformity. At stage 3, there's non-functioning tendon and a rigid deformity. These are the patients that are going to get a triple arthrodesis. So we're not even going to talk about them anymore because they're getting their arthrodesis. Stage 4, which was described by Meyerson, this is a modification of the Johnson classification, includes ankle valgus or ankle arthritis, which is another different animal. Totally adds a huge amount of complexity to the treatment. So we're going to talk mostly about stage 2 classification because that's where the controversy exists. This is a non-functioning tendon with a flexible deformity. Conservative measures are universal throughout the stages, so they include methods to decrease inflammation, to unload the posterior tibial tendon, and to correct or support the deformity. So with stage 1, patients may have a brief period of casting, physical therapy, and maybe an orthotic. And stage 1 conservative treatment is almost universally effective. Stage 2 and 3 patients may have a brief period of casting and physical therapy, but because of their deformity, they may require a much more elaborate orthotic. For stage 2 patients, I'll frequently use something like this, which we call an Arizona brace. It's a custom molded ankle-foot orthosis which completely controls the hindfoot, and this is really especially well tolerated by older patients who are less functional, but in the vast majority of cases, their symptoms will be well controlled with physical therapy and bracing, and we won't have to do surgery on them. So surgery, once again, is based upon classification. So stage 1, debridement and repair. Stage 2, there's a number of procedures, and that's what the bulk of this talk is going to be about. Stage 3 is arthrodesis, and stage 4 traditionally was arthrodesis, but with recent advancements in deltoid ligament reconstruction, maybe we can salvage some of these feet and ankles as well. So for stage 1, debride and repair the tendon. Pretty good relief at 30 months. Not perfect, but pretty good. You may do some associated boning procedures and tendon transfers. For stage 2 surgical treatment, there's very few controlled studies, but the goals of surgery are universal: relieve pain, improve function, and correct deformity. Initially, patients were treated with postertibial tendon repair and flexor digitorum longus or flexor hallucis longus tendon transfer. And this gave excellent relief of pain, but no correction of deformity. And experience showed that if we did not correct the deformity, the patient's symptoms would invariably return. So just a simple soft tissue repair for stage 2 deformity is probably considered no longer appropriate. But here's how you do the postertibial tendon debridement with the FDL transfer. So here's the postertibial tendon. You can see there's a lot of fluid around the tendon that normally isn't there. And then there's a longitudinal split tear within the tendon. The tendon's not always torn. Sometimes the tendon's torn in continuity. So you debride the defective portion of the tendon, which is always enlarged. Now you can see normal tendon, normal striations within the tendon. Whoops. And then you repair this tendon in a side-to-side fashion. But that's not really enough. We have to reinforce this tendon and strengthen this tendon. So we'll take the flexor digitorum longus tendon, which is right behind the postertibial tendon, and tenotomize it at the knot of Henry where it crosses over the FHL. And then there's a number of different ways to do this, but I'll do this through a drill hole using an interference screw and transfer the flexor digitorum longus tendon adjacent to the insertion of the postertibial tendon, and that will provide a nice reinforcement for the postertibial tendon. So that's an isolated procedure. This is what I would do for a stage 1 postertibial tendon insufficiency. I would do this for stage 2 as well, but then you'd have to take measures to correct the deformity. And depending upon the deformity is how you pick the other associated procedures. So the majority of the literature describes boning procedures to correct the painful flat foot. So there's different osteotomies you can do and different fusions you can do. The most common osteotomy we do is a medial displacement calcaneal osteotomy. So here's the calcaneal tuberosity. We're looking at the calcaneus essentially from the top. So the Achilles tendon is right here. The postertibial tendon is going to come here. We've cut the osteotomy cut the calcaneus in a transverse fashion and shifted it medially about 1 centimeter or 1.5 centimeters and generally fix it with a screw. This is provisional fixation provided with a K-wire that we're going to use for a cannulated screw. This is done in conjunction with a flexor digitorum longus tendon transfer. And this is the most common procedure that you'll do for the adult flat foot in addition to the soft tissue procedure that we discussed before. So the medialization, see here we have the hindfoot valgus right here, and we've medialized the calcaneus. We medialize the gastrocnemius, so the gastrocnemius is no longer a secondary everter, and it decreases stress on the posterior tibial tendon repair and FDL transfer. And here's how it's done. So you can make a transverse oblique incision right behind the peroneal tendons on the lateral aspect of the foot. I'll initially go in with a saw, but I'm concerned about the medial structures, the neurovascular bundle, which is medially. So I'll just drill through medially and then complete the osteotomy with an osteotome. Once that's done, we're able to translate the calcaneal tuberosity medially, correcting the hindfoot valgus. It's important to stretch the medial soft tissue structures as well, so I'll put a lamina spreader in there and then fix it with the cannulated screw, which is being placed down here. So then literally just manually push the calcaneal tuberosity over, advance the guide wire for the cannulated screw, and then place the screw. And then tamp down that shelf of bone. And once again, you want about 1 centimeter of medial displacement of the calcaneus. So here's the osteotomy line, and here's the displacement. How does this work? Well, we've medialized the Achilles lever arm. In the normal situation, the Achilles is in this posteromedial quadrant of the ankle and subtalar joint motion. So this acts as a primary plantar flexor of the foot and a secondary inverter. When the foot, now hopefully this diagram that I've made makes sense, but when the hind foot everts, so now we've got hindfoot valgus, the Achilles tendon is shifted over to the posterolateral quadrant, so it becomes a primary plantar flexor and a secondary everter, exacerbating the position of hindfoot valgus. So if we move the calcaneus over medially again, we've medialized the Achilles tendon lever arm, and we've made the Achilles tendon an even more powerful plantar flexor and inverter. So medial displacement calcaneal osteotomy improves arch height, improves forefoot abduction, excellent pain relief, and patients have decreased fatigability. But it's kind of limited in its ability to correct forefoot abduction. So sometimes in the case of profound forefoot abduction, we'll do a lateral column lengthening. That involves so this is a diagram of the foot. Here's the talus, here's the calcaneus, cuboid, here's the tarsal bones. So we're going to do, in addition to our medial displacement calcaneal osteotomy, we'll go anterior, the anterior process of the calcaneus, and do a transverse osteotomy here and open that osteotomy up. So we've done an opening wedge osteotomy of the calcaneus. That shifts the abducted forefoot back into neutral position. So by lengthening the lateral column of the foot, we've corrected this forefoot abductus situation. Combined with medial soft tissue procedures, it can be a standalone, or in the case of very profound flat foot, it can be done in conjunction with a medial displacement calcaneal osteotomy. So indications are stage 2 posterior tibial tendon insufficiency with hindfoot valgus and significant forefoot abductus. In my hands, if on the AP X-ray there's greater than 50% uncovering of the talar head, then I will consider doing a lateral column lengthening. And here's how I'll fix it. I'll take some allograft bone and I'll fix it with a plate. This is using a different type of plate, a wedge plate, but it's the same thing. So an incision in the anterior process of the calcaneus, retract the flexor or the extensor digitorum brevis, retract the peroneal tendons, and then do a transverse osteotomy, very similar to our medial displacement calcaneal osteotomy. This is done about 1 centimeter to 1.5 centimeters proximal to the calcaneal cuboid joint. I'll measure the depth of the calcaneus here because I wanted to maintain an intact medial hinge of bone because I don't want to completely destabilize this osteotomy. So I'll go through to the appropriate depth with the saw and then spread it using a lamina spreader and look at the x-ray and make sure that my forefoot abduction deformity is adequately corrected. In this case, I think the plate has an integrated wedge, a metal wedge that's going to hold the position of the osteotomy and then backfill the defect with bone graft. You can see we're fixing the plate, and then you look at the opening wedge effect, and you can see here, excellent talar head coverage. But here's our opening wedge. And then if you look down here, whoops. think we'll find it. Excellent talar head coverage. So excellent correction of the forefoot abduction deformity. And then I'll backfill that defect with bone graft, and typically I'll use a cancellous allograft. So a guy named Manoli popularized the double calcaneal osteotomy, and in typical fashion he called it the All-American. This is for severe hindfoot valgus with severe forefoot abduction. And you can get excellent correction. So here you'll see the clinical correction with a combined osteotomy. So complete correction of the forefoot valgus, hindfoot valgus, forefoot abductus, complete correction of the arch. Now we're not doing this for cosmetic reasons. We're doing this because we know that if you leave significant residual deformity after a posterior tibial tendon repair, the patient's symptoms are going to return. Then we end up with addressing forefoot supination. So there the foot's flat on the ground. If we correct the hindfoot valgus, the forefoot goes into supination. And frequently that's a problem when you're correcting really severe flatfoot deformities. So there the hindfoot's in valgus. If we bring the hindfoot back into a neutral position, the forefoot tends to supinate. And you can see that on this x-ray where in this standing position, this was one of my patients that I did a really significant correction of her flat foot, but she ended up with significant elevation of the first ray. So the first metatarsal head's completely off the ground. This patient's going to predictably complain of lateral midfoot pain because of overload here, because of residual forefoot abduction, because the foot wants to stand as a tripod. And Dudley Morton, who kind of popularized this idea, said that if the stress of the body weight transmitted through the leg falls outside of this triangle, then trouble is likely to follow. And I've seen that clinically in my practice when I haven't appropriately corrected this deformity. So this can be corrected surgically. It needs to be recognized preoperatively, but it can be corrected intraoperatively with a plantar flexion osteotomy. This is a cotton osteotomy. And here you see that's the extensor of the big toe. We're doing a opening wedge osteotomy through the medial cuneiform. And you can see as I open up this osteotomy, you're going to see the first ray is going to plantar flex significantly. So we're going to correct that forefoot supination deformity with this osteotomy. And here's the x-ray. You can see this is once again a wedge, a plate with an integrated wedge. And you can see good incorporation and good healing of the opening wedge osteotomy. And here you can see the actual osteotomy lines that have healed. Now in the United States, we've started using trabecular metal wedges. These are tantalum wedges, so it's a titanium type of metal that gets avid bony ingrowth, so it obviates the need for plate fixation. It's just a little bit faster, and it'll provide great correction of deformity. Now in the case, I don't know if you remember the patient from here, that patient had significant instability of the tarsal-metatarsal joint, and sometimes that needs to be addressed as well, because if you don't have a stable tarsal-metatarsal joint, then you're going to have some residual flatfoot deformity as well. And here you can see first ray hypermobility that was present on the patient that we saw in the clinic here. So this medial column instability can not only lead to residual flatfoot, residual dissatisfaction, but it can also lead to a significant bunion deformity. So frequently I'll have to correct this bunion deformity in the face of a flat foot. So here you can see pes planovalgus with some break at the talonavicular joint and the navicular cuneiform joint. And here we saw the preoperative deformity and preoperative x-ray. Postoperatively, we've got good correction of the bunion deformity and excellent correction of the talonavicular joint and navicular cuneiform joint through this first tarsal-metatarsal fusion. So these medial column procedures are combined with calcaneal procedures to provide a stable tripod for adequate weight bearing, appropriate weight bearing after posterior tibial tendon repair. Another thing that we occasionally do, and this becomes confusing, and so it's important to recognize all the elements of deformity and recognize what tools to address those deformities are in your armamentarium. So one thing that I'll occasionally use is a subtalar arthroresis. Now this is an implant that goes into the sinus tarsi, and it works on the principle of sinus tarsi closure. So this is a hindfoot varus situation, and you can see the sinus tarsi is wide open. In hindfoot valgus pes planus, the sinus tarsi closes down. So the idea behind the subtalar arthroresis is if you put an implant in the sinus tarsi, you elevate the talus, you kick the hindfoot back into neutral position. So it directly reduces the calcaneus. Remember, the calcaneus rotates externally from underneath the talus. So if we've reduced the calcaneus, we've restored that support of the calcaneus beneath the talar head. It improves pes planus, improves hindfoot valgus, and improves forefoot abduction. So it does almost everything. It's not really widely performed by orthopedic surgeons, but I think it's a really powerful tool that can allow us to maybe avoid some of the problems with multiple calcaneal osteotomies. It's an internal splint that protects an extensive medial soft tissue repair during healing and may obviate the need for other types of calcaneal osteotomies. In my hands, it's almost always done, however, in the presence of a medial displacement calcaneal osteotomy. And it's really easy to do. So this is about how long it takes. You put a small incision in the sinus tarsi, put a little guide wire through the sinus tarsi, through the tarsal canal, and then there are some spacers, some trials that you place in the sinus tarsi to make sure that you're correcting adequately. Here you can see the forefoot abductus that we do dynamically with simulation views. You see the navicular really uncovering the talus with forefoot abduction. So we put our trial in and our forefoot abduction. We want to maintain about 5 degrees of hindfoot pronation, but you can see our talonavicular joint is really well covered here now after placement of that trial implant. Then we put the permanent implant in. This is an absorbable implant, but it goes to the appropriate depth. And this reliably corrects a lot of the deformity that we previously had to use a lateral column lengthening for. But it's so easy that it might be very attractive to place, especially in an adult, without doing the appropriate other osteotomies or other appropriate soft tissue procedures. So I'd warn you against using it as an isolated procedure in an adult. So here's my algorithm for the stage 2 flat foot. For stage 1 posterior tibial tendon deficiency, I'll do an FDL transfer, posterior tibial tendon repair, and maybe an arthroresis to protect my soft tissue repair. For stage 2, I'll do an FDL transfer, arthroresis, and medial displacement calcaneal osteotomy. If there's stage 2 posterior tibial tendon deficiency with significant tail and navicular uncoverage, then I'll add a lateral column lengthening. Here's some clinical examples. This patient had some forefoot adductus deformity and pes planovalgus. And you can see she has obvious instability at the tarsal metatarsal joint with plantar gapping here. So she had a first tarsal metatarsal fusion, subtalar arthroresis, and calcaneal osteotomy. What about the role of the Achilles tendon? The Achilles tendon is an important deforming force around the hindfoot. And isolated gastrocnemius tightness is almost universal with these patients with posterior tibial tendon insufficiency. It may be present as a primary problem, or it may develop because as the foot flattens and the calcaneal pitch lowers, the calcaneal insertion is going to be relatively closer to the knee, allowing the gastrocnemius to contract. It significantly increases midfoot stress, and this Achilles tendon contracture significantly exacerbates arch collapse. So frequently, in addition to all the other procedures I'll do a gastrocnemius recession, and this can be performed endoscopically, which saves incision and also protects the sural nerve. So this patient has obvious isolated gastrocnemius tightness. A small incision is made about the midpoint of the fibula, but on the posterior medial aspect of the leg to avoid the sural nerve. The incision is placed through the skin and the crural fascia. And then stick your finger in and just palpate the gastrocnemius aponeurosis, and you can feel it there. You can feel the crural fascia. And then go in with the scope. In this system, the scope is integrated with a blade. So the scope goes in with a blade, and you do the gastrocnemius release. Here I'm just preparing a track to place the scope, but once the scope is placed, you can see the gastrocnemius aponeurosis, where the gastroc comes in with the soleus to form the Achilles tendon, and there it is right there. And it's well visualized. You can see if the sural nerve, about 10% of the time, the sural nerve will be anterior to the crural fascia, so it's important to look for that. But you can see with using that integrated blade, we've done a complete release of the gastrocnemius aponeurosis and even some of the soleus fascia, which is appropriate, almost a fractional lengthening of the soleus. So this is a good way to lengthen the gastric soleus complex without over-lengthening. And I'd encourage you to consider this technique in your diabetic patients too, because over-lengthening of the gastric soleus complex can lead to heel overload, and you can get heel ulcers, which are almost impossible to correct in the presence of excessive Achilles tendon weakness. Now, one thing that also contributes to a flat foot deformity and has until recently been a very difficult problem to address is chronic deltoid ligament insufficiency. Remember, the deltoid ligament has a bunch of components, including the superficial deltoid, which primarily supports the subtalar joint, and then the deep deltoid, which supports the tibio-talar joint. You can see this patient has bilateral complete deltoid insufficiency. So this was a difficult problem that for a long time was treated with pan-talar fusion. Now an isolated ankle fusion is really well tolerated, an isolated subtalar fusion is really well tolerated, but once you fuse the tibio-talar and the subtalar joint, the gait disturbance is such that even though you can get good pain relief, patients are very, very dissatisfied. So a certain element of patients with this stage 4, remember stage 4 is a flat foot deformity that includes either ankle arthritis or deltoid insufficiency. If they have a passively correctable situation, then you can treat this ideally with a flat foot repair and a deltoid ligament reconstruction. If patients have a non-correctable deformity, you might be able to do a flat foot repair and an ankle replacement. So there's been a lot of advances in treating these conditions, and hopefully these advances are leading to increased patient satisfaction. So a bunch of soft tissue reconstruction options have been described for the deltoid ligament. Most have focused on both the superficial and deep deltoid ligament, and in the case of a flat foot, it's important to focus on both the superficial and deep deltoid ligament. Many of them are complex. Probably the simplest ones involve allograft, perhaps a suture button for cortical fixation, and then interference screw fixation for the foot. So I think this may be how we do it here. Oh no, that's just, here you go. This is my, you can see this patient has had a triple arthrodesis, so had a stage 3, but had significant deltoid insufficiency. And you can see that deltoid insufficiency evidence on the fluoroscopy here. See how he goes into valgus just with manual stress. So this is my typical bloodless technique. There is a guide wire that's placed into the tibia through the medial malleolus. And this is going to be the insertion site of our allograft. And the allograft is going to reconstruct both the superficial and deep deltoid ligaments. The guide wire is going to be over-drilled to create a tunnel to allow passage of our allograft. And there you see the allograft. You can see a suture button up here, which is going to provide cortical fixation on the tibia. And here's the 2 limbs of allograft, one of which is going to reconstruct the superficial deltoid and one of which is going to reconstruct the deep deltoid ligament. So you can see our track here is appropriate. Now we're doing drill holes in the tibia and in the calcaneus. And the appropriate position has pretty much been well determined. So there are anatomic landmarks that allow you to reproducibly reconstruct these tendons, or these ligaments. And then interference screw fixation in the foot. So now we're done here. If we stress this ankle, even though we've reconstructed the ligament, you can see there is actually a little bit of residual valgus insufficiency. And that's something that's shouldn't really be tolerated. So with this system, there's a way to secondarily retension the allograft. It's very subtle insufficiency, but by pulling on these sutures, we can add tension to the allograft and we can completely stabilize the ankle. So this is a great way to salvage these previously very difficult situations. This is a 28-year-old female who obviously has some failed surgery in the forefoot, and she has chronic deltoid insufficiency bilaterally. This is a patient who would not tolerate a tibio-talar calcaneal fusion. She's actually otherwise healthy. So we did, this is 4 years post-op. We've got great correction. So here's her valgus insufficiency, worse on the left than on the right, but present bilaterally. And then her forefoot deformity, which probably needs to be corrected, especially her medial column, so we can stabilize the medial aspect of the foot. And here she is 4 years post-op, and she's functioning quite nicely with a very durable correction of deformity. So this is a patient who had, I'm not sure what she had, but it was clearly a failed attempt at correcting a flat foot. Here she is on a lateral view. On an AP view, you can see her flat foot deformity is so profound that she's developed a stress fracture of her fibula, and she's also developed stress insufficiency where the lateral half of her tibia has become impacted. So you can see that there. The medial half of her tibial articular surface is fine, but the lateral half is impacted because of chronic stress and insufficiency. So this is a patient that would otherwise probably get a pan-talar fusion, but she had dysfunction on the other foot, and we were hoping to salvage that foot. So we did a number of different things, including a fibular osteotomy, a tibial osteotomy, a triple arthrodesis, but you can see her hindfoot correction is excellent on the lateral and on the AP. Her ankle correction through an opening wedge osteotomy of the tibia and fibula and a deltoid ligament reconstruction. She's in neutral position now, and this has lasted her about 4 to 6 years. So eventually she's going to have arthritis of her ankle. Eventually she's going to need something done. But ideally, by correcting her hindfoot position, we can do an isolated ankle procedure as opposed to both an ankle and hindfoot procedure. So reconstruction of the deltoid ligament may also allow for salvage of the arthritic ankle joint. So this is a patient who had a triple arthrodesis and has significant ankle valgus. This is a situation where maybe you can retension the deltoid ligament through your ankle replacement with ligament balancing, but sometimes you're not able to, and so there was still some residual ankle valgus, which isn't well tolerated and shouldn't be accepted. So this patient underwent a deltoid ligament reconstruction and has a good, durable, stable ankle. This is one of my residents' fathers, so I really don't want to mess him up because I'll hear about it. So these deltoid injuries, it's a new sort of frontier in terms of treating the adult flat foot, and I think it's really expanded our ability to salvage these situations. So rotational deformities in the adult flat foot are described in linear and angular terms, and bony procedures are used to correct a largely soft tissue problem. The medial displacement calcaneal osteotomy should probably be used in all stage 2 flat foot deformities. The lateral column lengthening is extremely powerful, but maybe a little bit too powerful, and you could throw some people into varus, which is not well tolerated. And medial column procedures may correct or prevent lateral forefoot overload and correct the forefoot supination that you see in a lot of these patients. So medial soft tissue repair should always be included, and techniques for medial soft tissue reconstruction, including deltoid reconstruction, continue to evolve and have made previously unsalvageable procedures very treatable. And I think it's important to remember the subtalar arthroresis and spring ligament repair. These may protect medial soft tissue procedures and decrease the need for other procedures, including lateral column lengthening. Thank you very much.
ขออนุญาตสรุปสั้นๆนะครับเพราะว่าอันนี้จะค่อนข้างไปทางศัลยกรรมเยอะมากนะครับแต่ว่าค่อนข้างมีประโยชน์เพราะว่าการผ่าตัดแก้ไขเท้าแบนไม่ใช่เฉพาะว่าจะต้องเชื่อมข้อต่ออย่างเดียวนะครับก็จะมีทั้ง procedure ที่เราจะต้อง fix ทั้งตัว soft tissue เองตัวเส้นเอ็นต่างๆนะครับแล้วก็ตัวligament ที่อยู่รายล้อมข้อเข่าที่มีความจำเป็นนะครับซึ่งก็ขึ้นอยู่กับปัญหาที่คนไข้มีนะครับเราต้องดูตรวจให้เจอว่าคนไข้มี deformity ที่ระดับไหนนะครับแล้วก็ approach ให้ถูกทางนะครับก็จะมีทั้งการดูที่ตัว spring ligament นะครับเพราะส่วนใหญ่เวลาเท้าแบนX-ray เราก็จะเห็นชัดเจนว่าเหมือนตัว talus headมันจิ้มลงนะครับมันจะทำให้ตัวspring ligament ขาดหรือว่ามีปัญหาได้แล้วต่อมาก็คือ superficial deltoid ligament นะครับก็พวกกลุ่มmedial tibial talus ligament นะครับหรือว่าเป็น superficial รอบๆตัวด้านในนะครับก็ต้องเช็คด้วยแล้วก็สุดท้ายก็คือที่มีปัญหาอยู่เป็นประจำก็คือ posterior tibial tendon ก็จะเป็นพวก micro tear หรือว่าเป็นมีพังผืดอยู่ในเส้นเอ็นนะครับก็ต้องซ่อมไปด้วยใน soft tissue ทั้ง3ตัวนี้นะครับก็จะเป็นทั้งตัว dynamic แล้วก็เป็นตัว static stabilization ของตัวข้อเท้านะครับก็ต้องเช็คดูแล้วก็approach ให้ถูกทางนะครับแล้วก็เราใช้classification ที่เป็นตัวบ่งชี้ในการผ่าตัดเหมือนกันนะครับไอตัว Johnson Stone classification นะครับก็จะมี level 1, 2, 3, 4 นะครับก็ถ้าเป็น level ที่1ก็อาจจะเป็น soft tissue แล้วก็อาจจะมีทำขึ้นอยู่กับว่าถ้าคนไข้มีcalcaneal valgus ก็อาจจะมีเหมือนกับตัดตัวกระดูกส้นเท้าจัดให้มันตรงมากขึ้นตามbiomechanics ที่ดร. McWilliam สอนนะครับถ้าเป็นระยะที่2อาจจะยากหน่อยนะครับเพราะมันจะมีทั้งที่เป็น soft tissue procedure เองหรือว่าจะเป็นร่วมกับ มีเป็น osteotomy ขึ้นอยู่กับ deformity แล้วก็ stage ของระดับที่2นะครับถ้าเป็นมัน advance ไป2เกือบ3ก็อาจจะมี procedure ที่ค่อนข้างคล้ายกับเหมือนกับเป็นกระบวนการที่ยังไม่มีการเชื่อมนะครับแต่ว่าต้องดูทั้งหมดอาจจะมีทั้งตัว MDCO นะครับ Middle Deviation Calcaneal Osteotomy มี Evan นะครับก็คือ lateral column lengthening แล้วก็มี Cotton ก็คือเป็น first leg plantar flexury osteotomy ที่คือในฟอร์มนะครับแล้วก็ถ้าเป็นสเตจที่3ส่วนใหญ่สเตจที่3ก็จะมี subpterygoid ที่ค่อนข้างเสื่อมนะครับแล้วก็ต้องทำ triple arthrodesis ไปร่วมกับ soft tissue ที่ต้องดูด้วยไม่ว่าจะเป็นตัว posterior tibial tendon เองตัว spring ligament เองหรือเป็น superficial deltoid ligament นะครับแล้วก็สเตจสุดท้ายก็คือสเตจที่4ซึ่งจะเห็นจากตัวอย่างภาพของX-ray ที่ดร. McWilliam เขาโชว์นะครับก็จะเป็นพวก plantar arthritis ก็จะมีการเสื่อมทั้งตัวข้อเท้าแล้วก็ตัว subpterygoid การรักษาก็ต้องเป็นการเชื่อมข้อเท้านะครับหรือจะเป็น plantar fusion นะครับแล้วก็การที่จะซ่อมตัวใดตัวหนึ่งมันไม่ได้นะครับเราก็จะมีการบอกวิธีการเล็กๆน้อยๆนะครับว่าถ้าจะทำ MDCO จะขยับตัว calcaneal fragment ไปกี่เซนติเมตรmedially นะครับแล้วก็การตัดกระดูกสำหรับ lateral column lengthening ควรลงใบมีดที่ตรงไหนนะครับก็ประมาณ1เซนติเมตรถึง 1.5 เซนติเมตรนะครับแล้วก็เรื่องของbiomechanic ของตัว Achilles tendon ที่จะช่วยหลังจากทำ MDCO นะครับก็มีประโยชน์มากเช่นกันซึ่งทั้งนี้ทั้งนั้นนะครับโดยรวมแล้วจะต้องดูเป็น deformity เป็นส่วนๆไปนะครับถ้าทั้งการตรวจร่างกายแบบลงน้ำหนักเองการขยับข้อต่อเองหรือว่าการดูฟิล์มเอ็กซเรย์นะครับก็จะช่วยวางแผนในการรักษาได้มากเมื่อกี้ที่อาจารย์ท่านเสริมไปนะครับเรื่องของ CT scan นะครับก็จะเห็นว่ากระดูกโดยเฉพาะทางด้านข้างจะมีการลงน้ำหนักมากขึ้นหรือมี impingement นะครับใน CT scan แล้วก็ถ้าเป็น MRI ส่วนใหญ่จะไม่ค่อยได้ข้อมูลสำหรับข้อมากนักแต่ว่าจะได้ข้อมูลเกี่ยวกับsoft tissue นะครับไม่ว่าจะเป็นพวกscar tissue หรือว่าเป็นsynovitis ของตัว tendon หรือว่าภาวะที่มีความผิดปกติของ soft tissue ต่างๆนะครับแล้วก็สุดท้ายนะครับสำหรับการผ่าตัดซ่อม deltoid ligament นะครับเรามีเทคนิคค่อนข้างใหม่นะครับเป็นไทโลบที่มีอัลโลกราฟของตัว tendon นะครับมาช่วยเสริมความแข็งแรงของ deltoid ligament ซึ่งเป็นเทคนิคที่ยังไม่ค่อยแพร่หลายนักจะมีแพทย์ที่อเมริกาเองทำแค่ไม่กี่คนนะครับแล้วก็ดร. McWilliam เป็นหนึ่งในนั้นที่กำลังเทรนผมให้สามารถทำกระบวนการนี้ได้นะครับก็จะเป็นประโยชน์ต่อพวกเราในอนาคตแล้วก็ถ้าเฟลจริงๆส่วนใหญ่ก็จะมี recommend อยู่ก็คือมีทั้งฟิวเชื่อมตัวข้อเท้านะครับหรือว่าจะเป็นการทำtotal ankle replacement นะครับขึ้นอยู่กับกิจกรรมของคนไข้แล้วก็วัยของคนไข้ครับแล้วก็เดี๋ยวจะเป็นหัวข้อต่อไปนะครับซึ่งจะเป็นเกี่ยวกับการผ่าตัด reconstruction ของ Charcot นะครับ
I have no idea what he said.
Basically everything you teach.
But it sounded good to me, so.
Thank you.
So now we're going to talk about surgical treatment of Charcot arthropathy. Charcot arthropathy, I think we've discussed it. It's a non-infective, destructive inflammatory process. It may be isolated. It may be activated by isolated trauma or repetitive microtrauma, and it manifests as dislocation, periarticular fracture, or both in patients who have decreased sensation due to peripheral neuropathy. Now, the most common cause of peripheral neuropathy we see is diabetes. In the United States, it's probably followed by alcoholic neuropathy. We almost never see leprosy, but I understand that that's a significant problem here. There are two theories of pathogenesis, two theories of why this is caused. There's the neurotraumatic theory, and then there's the neurovascular theory. In the neurotraumatic theory, it's thought that repetitive microtrauma leads to overload of the bone subsequently leading to fracture and dislocation. So patients who have diabetes and peripheral neuropathy have an altered gait. You could think of it very simply as they step on their foot the same way every time. Like each step I take is probably mildly different than the last, and if I step on my foot the same way every time, I'll get pain feedback or proprioceptive feedback that'll tell me unconsciously not to walk that way. Diabetics don't have that. So if I walked a mile with my foot hitting the ground the same way every time, I'm going to break something. And diabetics don't have the pain feedback to know that they've broken something, so they just keep going. With the neurovascular theory, remember diabetes neuropathy includes autonomic neuropathy. So there's dysfunction of the vasomotor system. So these patients also get a tremendous increase in circulation to their feet. They get arteriovenous shunting. And a very simple way of thinking it, it's not completely accurate, but I think it makes a point, is that the calcium just gets washed out of the bone, and that leads to focal osteoporosis. In reality, it's probably a combination of neurotraumatic and neurovascular causes. And you can tell who the orthopedic surgeons are in the room because their eyes glaze over when they see this slide, because this shows sort of the biomechanical or molecular basis for Charcot arthropathy. It includes osteoprotegrin, which I can't even pronounce, which promotes osteogenesis. It involves the rank ligand, which activates osteoclasts. So osteoprotegrin is downregulated. Rank is upregulated by the rank ligand, so you get a mismatch in osteogenesis and osteoclasis. You get more osteoclasis, you get focal osteoporosis, and you get fracture because they don't feel their osteoporosis. This focal osteoporosis leads to fracture, dislocation, and deformity. The deformity leads to more altered weight bearing, and the altered weight bearing leads to skin ulceration. The skin ulceration leads to infection. The infection leads to amputation or even death. So it's a very serious problem that should be addressed as soon as possible. Risk factors include neuropathy, and then for me, probably a gastric soleus or Achilles tendon contracture. Obesity plays a role, and physical activity leads a role. Now, this foot looks like a foot from my last talk, so you can't really tell when someone walks in the room when they have a big swollen foot if they have Charcot arthropathy or something else. They may not have a history of trauma, and the vast majority of my patients don't know what happened. They may not have pain. They just notice that their foot is swollen and red and warm and deformed. So because of this redness, warmth, and swelling, it's difficult to distinguish Charcot arthropathy from infection. But there's a couple of clinical signs that may point to the way. Patients with Charcot arthropathy don't have a fever. Most patients with infection will have a fever, although fever is maybe less common in the immunocompromised diabetic patient. Patients with Charcot arthropathy won't display any signs of systemic illness. Frequently, patients with infection will be systemically ill. They'll show other signs of sepsis. Patients with Charcot arthropathy and no infection typically have an intact skin. Patients with infection will typically have ulceration. Here's the best sign that is most consistent. It's not always present, but if there's increased insulin requirements or alteration in blood sugar control, then I'd really think strongly about infection. Sugars are always normally controlled, or they're not always normal, but they're as controlled as typically in a patient with Charcot arthropathy. The white blood cell count is normal in Charcot arthropathy, may be elevated in the case of infection, but not always. One other really kind of soft clinical sign that's really valuable in the office is if a patient comes in with a red, hot, swollen foot, you just elevate their foot for 10 minutes. The swelling may not go away, but if the redness goes away, then it's less likely to be infected. So obviously you take a history as an orthopedic surgeon. That's probably something I avoid. Physical examination and imaging studies. Early x-rays may be negative. Late x-rays show obvious deformity. Bone resorption, osteopenia, metaphyseal and epiphyseal fragmentation, disruption of the articular surfaces, and finally dislocation of joints. MRI may be a useful modality to distinguish between Charcot arthropathy with or without infection, but the high intensity signal observed in the bone and periarticular tissues is frequently difficult to distinguish. So you could add IV contrast, but unfortunately a lot of these patients have renal insufficiency, and contrast may not be that advisable. There's a classification that's universal, the Eichenholz classification, and this is a classification that isn't based upon anatomy, but is based upon progression of disease. So it allows us a prognosis as to where the patient's going to go once they present to the office. So stage 1 is the fragmentation stage. There's erythema, warmth, and swelling of the extremity. This is the stage that's difficult to distinguish from infection. Initial radiographs may be normal, and some people will call that a stage 0, but later radiographs show fragmentation of subchondral bone without any evidence of healing. They may have fractures, dislocations, and subluxations, but they all look new. There's no fracture callus. There's no evidence of healing. Stage 2 is the coalescence stage. This is when healing begins. The swelling, warmth, and erythema are much less obvious, and radiographs show early signs of healing. You can see fracture callus in the areas of fracture and dislocation. And stage 3 is the consolidation or reconstructive phase. With further healing, there's union of fractured bone and deformed bone. There's maturation of fracture callus. There's bony remodeling. There's rounding of the sharp bone ends that are present at stage 1 and 2. So it looks like an old fracture. And frequently a situation of instability on physical exam will convert to stability on physical exam. So this is one patient going through the different stages. Stage 1 looks like a fresh Lisfranc fracture, right? But this is atraumatic in a patient with diabetes and neuropathy. So this is Charcot arthropathy. At stage 2, you can see consolidation across the areas of fracture and dislocation. And at stage 3, you can see frank healing, or in some areas, there's a stable non-union of bone. So that's the Eichenholz classification. And that can tell us what's coming next. So if patients are stage 1, you know you're in for a long haul. If they're stage 3, maybe they've even completely resolved and they're in the complete remodeling phase, and your treatment options may be different. The anatomic classification gives a different type of prognosis. It tells us which patients are more likely to require surgery, and it kind of tells us what their clinical course is going to be like in the future. This is based upon 3 types, and there are some subtypes that we're not going to get into, but a type 1 is most common. It's at the navicular cuneiform or tarsometatarsal joints. Stage 2 is the hindfoot or transverse tarsal joints, and stage 3 is at the ankle, with a stage 3B being calcaneal tuberosity. So with a type 1, remember this is a midfoot tarsometatarsal, metatarsal cuneiform type of fracture, dislocation, and deformity. It's a shorter period of consolidation, so these patients are going to run through the Eichenholz stages much quicker. They may develop a rocker bottom deformity and forefoot abduction or forefoot valgus deformity. And there's a very high incidence of ulceration over the bony protuberances. But these patients don't invariably need surgery. With a type 2 deformity at the transverse tarsal or subtalar joint, there's a longer period of instability and a lower incidence of ulceration. Although we'll see in this case the patient had an ulcer almost immediately after developing his deformity. So it doesn't hold true with everybody, but these are generalizations. Type 3 has remember that's the ankle joint or tibio-talar joint, the longest period of instability and the highest incidence of ulceration, suggesting that if you have a type 3 deformity, you might as well fix it now if you can. Due to high incidence of complications, conservative management is probably preferable than surgical management. The principle of conservative treatment involves protection until consolidation, so you're protecting the joint to prevent progression of deformity until the injury consolidates, followed by shoe modifications to protect bony prominences and prevent ulceration. So the workhorse in this case is going to be the total contact cast that Dr. Rafat alluded to. It's used during stage 1 disease. I change it frequently to account, number 1, to check the skin because these are neuropathic patients, and to account for decreased swelling because you don't want the leg pistoning up and down in the cast and causing shear-related ulceration of the foot. Weight bearing is probably okay in plantar grade feet, so you don't have to keep these patients off their feet, you just have to immobilize and protect them. And in most cases, at least after the initial swelling goes down, a pneumatic walking boot may work as well as a total contact cast, which is a little bit easier for patients. The problem with the pneumatic walking boot is compliance. And I know, at least in the United States, the biggest problem we have in treating our diabetic patients is compliance. Compliance in blood sugar control, compliance in foot care, compliance in recommendations in terms of activity, shoe wear, and foot protection. So this total contact cast or a pneumatic walking boot is used until early stage 2 disease for about 2 months. Then I'll transition these patients into a Charcot restraining orthotic walker. It's a molded clamshell AFO. It maximally protects bony prominences and distributes weight throughout the foot and leg, and it can offload the plantar aspect of the foot by up to 50% if it's made appropriately. It's used throughout stage 2 and through most of stage 3. So once patients are in late stage 3, then you can use shoe modifications, maybe a custom shoe if their deformity requires, a commercially available shoe that accommodates the deformity, and an appropriate insert that will accommodate the plantar deformity, or in many cases, they may get an ankle foot orthosis that fits into a shoe. So this is a 68-year-old, non-insulin dependent diabetes, peripheral artery disease, so no foot pulses, and 3 months ago he had a coronary angioplasty and he has a drug-eluting stent, so he's on an anticoagulant that he can't get off of for 12 months. He has, this is a type 2 deformity, you can see Lisfranc joint, but you can see tremendous bony prominence that predictably is going to lead to overload of the plantar skin and is going to lead to ulceration. So how many people think this should be fixed? What are you doing? Come on.
ระดับนี้คิดว่าจะต้องใช้ตัวฟิกคิดว่าจะต้องใช้ตัวฟิกอะไรไหมครับสำหรับการรักษาหรือว่าแค่ใส่เฟือกเฉยๆ
Nobody?
Immobilizations?
Yeah, because even though predictably, I would say this bony prominence on the bottom of the foot is going to lead to ulceration. His medical problems, his peripheral artery, he has no pulses in his feet. He hasn't developed ulceration, so we don't need to send him for a bypass. In fact, I think he's had multiple bypasses that have failed, and he has coronary artery disease. So medically, he's a very poor candidate. But you can see this is an Eichenholz stage 1. It looks very acute. The fractures are fresh. So we put him in a total contact cast, transition him to a pneumatic walking boot, and then finally a Charcot restraining orthotic walker. And now he's in shoes with an insert, and he's ulcer-free at 12 months. So this really shows how treating these patients is a team effort. So I really needed a lot of help from my orthotist to fix this. I needed a lot of help from the endocrinologist to make sure the patient's blood sugar is well controlled. And he's actually still doing well. Now, he may develop problems in the future, and he may lose his foot because he's probably still not going to be a surgical candidate unless we can figure out some way to restore circulation to his foot.
May I summarize this? May I summarize this?
Oh, sure.
สำหรับเคสนี้นะครับเป็นเคสที่ค่อนข้างมี comorbidity สูงนะครับจากที่อาจารย์หมอเขาบอกไปคือมีทำ bypass ที่หัวใจ3 เดือนที่ผ่านมาแล้วก็ไม่สามารถ take off จากไอตัว anticoagulant ได้ก็เป็น candidate ที่ไม่เป็นคนไข้ที่ไม่เหมาะกับการผ่าตัดนะครับเราก็เลยทำการรักษาด้วยการเข้า total contact cast ไปประมาณ2 เดือนแต่ว่าตามหลักที่พวกเรารักษาอยู่ที่นู่นนะครับถ้าเข้า total contact cast เราจะเปลี่ยนรายสัปดาห์เพราะว่าจะต้องมาเช็คลักษณะของผิวหนังของคนไข้ด้วยแล้วก็ลักษณะอื่นๆตามมาเพราะบางทีในช่วงแรกของตาม Eichenholz classification นะครับคือ developmental จะคนไข้ค่อนข้างบวมแดงนะครับแล้วก็รูปเท้าจะเปลี่ยนไวหลังจากที่เราเปลี่ยนไปทุกสัปดาห์เนี่ยก็จะทำให้ตัว total contact cast มันฟิตกับตัวเท้าคนไข้ได้ดีกว่าแล้วก็ตามที่ยกตัวอย่างครับเป็น claw walker claw boot นะครับก็คือ Charcot restrained orthotic walker นะครับก็จะเปลี่ยนตอนเดือนที่2ถึงเดือนที่14นะครับแล้วหลังจากนั้นถ้าดูช่วงcoalescence แล้วก็ consolidation ของเท้าคนไข้ว่ามัน stable ขนาดไหนถ้า stable ก็อาจจะเปลี่ยนมาใส่รองเท้าปกติได้แต่ว่าสำหรับเคสนี้ก็ต้องมาดู ตอนท้ายอีกทีเพราะว่าถ้าคือตอนนี้คนไข้ก็ยังอยู่ในช่วง12 เดือนสุดท้ายนะครับก็ยังคิดอยู่ว่าจะต้องมีการรักษาด้วยการทำ exostectomy หรือว่าเป็น reconstruction อีกทีเพราะว่าด้วยภาวะข้างเคียงของคนไข้นะครับก็ต้องดูไปควบคู่กันด้วย
So let me
Summarize
say
everything.
one more thing too. Okay, that you're going to summarize. Another thing you can see here, so this is Eichenholz stage 1. This is literally weeks after he noticed his deformity. And I didn't keep him non-weight bearing because he wasn't going to be non-weight bearing anyway. This guy would not tolerate 3 to 6 months of non-weight bearing. So put him in a total contact cast and then a pneumatic walker. You can see there's virtually no progression of his deformity despite weight bearing. So that suggests that these midfoot Charcots, these type 1 Charcot deformities, are amenable to early weight bearing. That's going to help the patient's quality of life during healing, and it's also going to help with their sugar control.
ก็สำหรับเคสนี้นะครับเวลาใส่เฟือกไปแล้วเราบอกให้คนไข้ออฟโหลดไม่ลงน้ำหนักที่เท้านะครับแต่ว่าด้วยความที่คนไข้ถ้าเราบอกขั้นหนึ่งเขาก็ไปทำอีกขั้นหนึ่งนะครับส่วนว่าเคสนี้คนไข้ก็เดินลงน้ำหนักอยู่ดีแต่ว่าด้วยความที่เป็นบรอสกี้เลเวล2นะครับแล้วก็ในช่วง development ไม่ของอันนี้มันจะไม่ทำให้มีการเคลื่อนไหวมากและไม่ค่อยจะทำให้เกิดแผลนะครับก็ท้ายที่สุดก็คนไข้ก็เท้า stable มากยิ่งขึ้นนะครับ
Doesn't he speak Thai well? So surgery is reserved for failure of conservative treatment. That's a progressive deformity in stages, Eichenholz stages 1 and 2, ulceration and infection, recalcitrant to conservative measures, recalcitrant to offloading, recalcitrant to debridement, in unshoeable or unbraceable deformity in all stages. So if someone comes in and their deformity is such that you know especially in the ankle, you know you're never going to get a shoe on them, then you might as well fix it now. But there is a high incidence of complication with this semi-elective Charcot surgery, including amputation. So you really have to balance your goals with the patient's ability to heal. The goals of surgery are to restore stability and alignment, prevent progression of deformity, facilitate functional ambulation, because if patients aren't walking, we've done them no favors, prevent ulceration, and facilitate footwear. It's important to think about preoperative considerations, including the vascular status. So if they need surgery and they have poor circulation, then they should get their they should get their circulation restored. If technically they can't get their circulation restored, then maybe they're absolutely not a candidate for reconstructive surgery. What about their prior surgical history? Do they have a lot of scars around the foot from prior injuries or prior surgeries? And how is that going to impact our incision placement? Diabetes control is critical because if they have a reasonable hemoglobin A1C, they're going to heal their wounds better, they're going to fuse their joints better. Nutritional status, similarly, if they have a normal albumin and prealbumin. And finally, their renal status, because it's important that they have a normal vitamin D and calcium levels to heal bone. It's preferable if the ulcers are healed, but that may not be possible in the face of infection, especially if the infection is preventing the ulcer from healing. And it may not be possible if the deformity prevents healing. It's also preferable to perform surgery in Eichenholz stage 3 when the patient's osteoporosis associated with the acute Charcot event has resolved as much as possible. So Dr. Rafat talked about ulcer debridement. There's also exostectomy. You can do osteotomies, arthrodesis, and hopefully not amputation, but sometimes you do have to amputate these limbs. So plantar exostectomy, here's our friend again. Plantar exostectomy is effective in the presence of a stable deformity. And this guy definitely has a stable deformity because he's been walking on it for a year now. You may have to do medial or lateral incisions. It offloads the plantar skin. So this prominent bone here will no longer be a source of excessive pressure and ulceration. It allows ulcer healing and prevents ulcer recurrence. And you really have to do a pretty significant exostectomy here. Because if you leave any spikes of bone, the patient's predictably going to get an ulcer there. Osteotomy and arthrodesis allow for correction of deformity, correction of instability. They allow patients to get into regular shoes and allow for ambulation. Fixation methods aren't important unless you aren't familiar with this typical or a particular type of fixation method. And it's also important to remember that these patients are relatively osteopenic. So standard fixation techniques, including just isolated screws or smaller plates, probably aren't going to work. The Charcot forefoot is relatively uncommon, and treatment principles are similar to standard forefoot surgery. So you want to correct the deformity, you want to straighten the toes, you want to normalize weight bearing on the plantar aspect of the foot. The goal is a stable, plantigrade, braceable, or shoeable foot. So this is a 57-year-old female with a relatively high body mass index. I don't think you see these body mass indices as much in Thailand, but she has significant deformity from her midfoot and forefoot. She's got toe dislocations. She's got a great toe dislocation. So we basically borrowed from the rheumatoid arthritis experience, fused her first ray, and did lesser metatarsal head resections. And now she's got, it's not a normal foot, but this is a foot that's going to fit into a shoe. She's no longer going to have the metatarsal head prominence that she had that's causing plantar ulcerations, and she's much happier with this foot. The Charcot midfoot leads to a rocker bottom deformity. It's the most common location in the foot. It's also the most common location where surgery is required because there's a relatively higher incidence of ulceration here. You get indications for surgery here, once again, include recurrent ulceration, osteomyelitis, progressive deformity, or gross instability. As always, the goals are restoration of a stable, plantigrade, braceable, and shoeable foot. You want to heal the soft tissues, resolve the infection, and avoid amputation. So in these cases, an extended medial column fusion is appropriate. Rigid internal fixation, remember these are osteopenic patients, so standard internal fixation techniques aren't going to work. And I use a lot of adjunctive external fixation, so I'll use a circular external fixation system so patients can walk. Because even with this fixation, I don't let these patients walk until there's definitive evidence of healing. But if I add an external fixation system, especially, my patients are non-compliant until proven otherwise. So if I put an external fixator on them and they walk, then they'll be safe in doing that the vast majority of the time. So there's an extensile medial incision. Remember, this is a rocker bottom deformity. So we're going to take out a wedge of bone that's going to be based plantarly and medially. So it's going to allow for correction of the rocker bottom deformity and the associated forefoot abductus. Sometimes you need a lateral incision, so you have to take out all this bone so that you can hook up the forefoot to the hindfoot. Fixation options include screws, plates, external fixation. Standard screw fixation is probably not adequate because of this hypervascular osteopenic bone. Axial screw fixation adds a certain element of strength. It's kind of technically difficult and may require some increased exposure, but it's a great tool to give you stable fixation of the midfoot. Standard plate fixation techniques using, for example, a 1/3 tubular plate and 3.5 millimeter screws probably isn't enough. Plantar plating adds, you apply this plate to the plantar aspect of the first ray. It's a tension band technique. It enhances fixation of osteopenic bone. It's a very strong construct. So this is much preferable than your standard medial plating techniques. If you look at the strength of repair, plantar plating may be stiffer than intramedullary screws. The problem is it requires a very large exposure, and it can be difficult to stabilize the talonavicular joint because of the sustentaculum. Extended medial column plating, you've already done the exposure there. If you can get the appropriate plate, maybe that's beneficial. It's technically easier than an intramedullary screw placement. So this locked medial plating enhances fixation in the osteopenic bone. The construct stiffness may surpass that of plantar plating, especially if you have a locked plate that's placed in multiple planes. And the I-beam effect may result in a lower incidence of plate failure. So here's an example of a plate, multiple planes of fixation because of the curve of the plate. You have these dynamic compression screw holes. So not only do you get excellent fixation, but you get compression across the tarsal-metatarsal and navicular cuneiform joints. And you can see the compression here as you fix the dynamic screw. So that might be a reasonable alternative. Whatever you're comfortable with, you just have to make sure that your fixation technique is strong enough. Lateral column fusion, I try to avoid. Lateral column motion, the fourth and fifth tarsal metatarsal joints, that's important, because it allows us to accommodate uneven surfaces on the ground. So there may be a higher incidence of lateral forefoot ulceration if you have to fuse the lateral column. So here's a 50-year-old female. She has an acute dislocation of her navicular. There's very little fracture going on here. So this is an isolated or almost isolated ligamentous Charcot foot that's not expected to heal. There's no fractured bone that you'd expect to heal. So this is an unstable situation that's probably not going to return to stability. So this is something that I would fix acutely as long as medically she's stable and she had adequate circulation. So she had an extended medial column fusion with a plate, and I did excise the navicular. So here's an example of the typical midfoot deformity. Pes planus, forefoot abductus, a big ulcer beneath the medial cuneiform, and osteomyelitis. So he underwent resection of a plantar and medially based wedge resection of the foot with extended medial column fusion. You can see him, he had adjunctive external fixation because he was absolutely non-compliant and he was weight bearing on it. So here he is before, here's his deformity before, here he is about 3 months afterwards with a healed ulcer, and he's bearing weight. Now he, interestingly, he's developed some forefoot issues, and he's got some ulceration of the forefoot, probably from rigid stabilization of the medial column. So these patients keep coming back with different problems that, and a lot of these problems you can't predict. Achilles tendon lengthening or gastric soleus lengthening is an important adjunct in these patients because it absolutely offloads the midfoot and forefoot. And I'd prefer gastrocnemius recession because there's not excessive weakening of the gastric soleus complex and a lower incidence of heel ulcerations. I use a lot of external fixation. It allows for fixation remote from the infection. It obviates the need to extend the exposure so you can put a big plate on there. The tension thin wire fixation is very strong and in most cases will allow for early weight bearing and osteopenic bone. So this is the worst patient combination. Diabetes, chronic renal failure on dialysis. She's got an ulceration that keeps coming back here. You see her foot. She's got dislocation of the ankle. I don't know where her talus went. You can see on the CT scan she virtually has no talus, so there's a high index of suspicion for infection here. So she's not really a candidate for intramedullary fixation of her ankle and hindfoot. She's not really a candidate for screw fixation. You can see there's virtually no talus, a little bit of talar body. So she underwent an attempt at an extended fusion. You can see on the x-ray we placed the calcaneus back underneath her tibia, and on the lateral, as much as you can see, it looks like it's lined up pretty well. But she actually didn't get a solid fusion, which isn't surprising given her diabetes, dialysis. So these patients are very difficult to fuse, but she did have a stable arthrofibrosis that allowed her to walk and keep her foot. This is a 62-year-old female that had a remote history of an ankle fracture, and she came into the office with a hot, swollen ankle, and she clearly has an infection. This was a two-stage situation, so I'm going to have to resect this infected bone and then figure out a way to fuse her calcaneus to her tibia, and there's a lot of infected bone to remove there. So we remove the infected bone, we put in an antibiotic impregnated cement spacer, fixed her with an external fixator, with the idea that eventually we're going to fuse the calcaneus to the tibia, but you can see there's a lot of bone loss. So she'd have about a 5-centimeter leg length discrepancy because of that. So we decided to extend the external fixation system and do distraction osteogenesis proximally to correct her leg length discrepancy and do a simultaneous closing of the tibial calcaneal joint to create a fusion. And she, once again, she has a stable arthrofibrosis, I think. She's been around for about 4 years. I don't think this is solidly healed, but her leg lengths are equivalent, and she's walking with an AFO. This is a 52-year-old male with a high body mass index. He's got diabetes that's otherwise well controlled, even though he weighs about 400 pounds. And he came in the office with a swollen foot that didn't hurt. He'd already started to ulcerate. So this is not a situation that I think is, especially given instability here, that's not going to resolve. His high body mass index, this isn't a situation that's going to likely be well treated conservatively. And you can see how the chronic contracture of the Achilles tendon is going to continue to pull the calcaneus up, putting tremendous stress on the midfoot and forefoot. And there's his ulceration. And once again, you can see the effects of Achilles tendon tightness. Here's his ulcer. You can see he's got a little bit of cortical disruption, so it's important to make sure he doesn't have an infection there. And because of that, I was only going to use limited internal fixation for provisional fixation. But we got frozen sections. There was no infection visible, so we put on an external fixation system. And he's got incomplete correction, but he's got a stable plantar grade foot, and he's been walking for a number of years with this. He developed some toe problems, but otherwise he's doing pretty well. Now, intramedullary nailing is a valuable tool, particularly for ankle Charcot arthropathy. It requires preparation of the tibia-talar and subtalar joints, but it does because it's such a large implant, you don't want to put it in the face of infection. This is a 58-year-old lady with chronic deformity. She didn't have much pain, but you can see she gets recurrent ulcerations on the lateral aspect of her ankle here. So we did a tibio-talar calcaneal fusion. This is a 56-year-old male, once again, with a very high body mass index. You can see his talus is overlapping his calcaneus. His calcaneus is articulating with his fibula because he's got a subtalar dislocation. You can see half of his talus has eroded, and you can see the articulation, almost a pseudarthrosis between his calcaneus and his fibula. And you can see it here on this CT scan, 3D CT. So he had fixation with a nail, and I added the external fixation system because of his high body mass index, and I knew that he wasn't going to be able to be compliant with non-weight bearing. Post-operatively, he's got good deformity correction. 12 months post-op, you can see there's a little bit of migration of the nail, but otherwise he has a solid, stable fusion. So this is kind of an interesting thing. I don't do total ankles on diabetics with neuropathy, but someone did. And he had multiple revisions, and he's got a clearly unstable loose prosthesis. And in this case, despite his diabetes and neuropathy, he had a lot of pain. Otherwise, I'd probably leave this go because his foot was otherwise plantar. So we had to take out the prosthesis, and that left a very large void. So we used fresh femoral head allograft. But the fresh femoral head allograft has no circulation to it, and there's really not a lot of great circulation here. The soft tissues aren't that great because of his multiple surgeries. So we took the peroneus brevis and in a reverse fashion laid it over the allograft to add some blood supply to the allograft, and he actually healed pretty nicely. And so that's a big win. But this is showing how the combination of internal fixation with external fixation will provide a rigid construct to promote healing and allow these otherwise neuropathic patients to walk. I think we're getting near the end. So this is a 60-year-old male. Here's his right foot and ankle. You can see it's a lateral of his tibia, but almost an oblique or an AP of his foot because he's got a subtalar dislocation here. And he actually came in, he had an ulcer right here, as you'd expect, right beneath his cuboid, but he came in because his left ankle was painful and swollen, and he'd apparently had a previous triple arthrodesis and now has an obvious infection. So once again, we used an antibiotic cement spacer to resolve the infection. Later on, did a tibial calcaneal fusion. And then once this had resolved or had shown itself to be reasonably stable and infection resolved, we came back and we fixed his right foot with a tibio-talar calcaneal fusion with a plate and an external fixation. Here you can see on the lateral solid fusion on the right, probably an arthrofibrosis on the left, but he has a stable plantar foot, and he's walking with AFOs bilaterally. So conservative treatment is preferred and frequently successful for Charcot arthropathy. Expect protected weight bearing until consolidation, and then shoe modifications and bracing to accommodate the deformity. Surgery is reserved for failure of conservative treatment or when the instability or deformity is obviously not going to be amenable to shoeing or bracing. Surgical techniques include exostectomy, which is the easiest technique and the least complex and most likely to heal. There's realignment and fusion for more complex deformities. And fixation methods are whatever you're comfortable with, but just make sure you respect the fact that these patients are osteopenic and they need stable fixation or they're not going to heal. Expect prolonged protection, non-weight bearing for 3 to 6 months in these patients. X-fix may allow for early weight bearing, postoperative bracing for 12 to 18 months in a crow walker, and then a shoe or orthotic to accommodate deformity. Then after that, even though they've healed, you need regular follow-up for continued reinforcement of patient education and to assess for progressive deformity. The goal is a plantar-grade, braceable, shoeable foot that will allow ambulation. Khab kun krab.
เดี๋ยวจะขอสรุปสั้นๆนะครับเพราะว่าสำหรับการทำ Charcot reconstruction จะค่อนข้างยากและต้องพิจารณาเป็นเคสไปนะครับfixation ที่สำหรับเคสคนไข้เคสของการ reconstruction นะครับจะต้องดูในเรื่องของแผล timing ที่ถูกเวลานะครับส่วนใหญ่จะสามารถทำการผ่าตัดระหว่างที่มีแผลได้ไหมทำได้นะครับแต่ว่าส่วนใหญ่ต้องการทำหลังจากที่แผลหายหรือว่าสามารถควบคุมภาวะการติดเชื้อของแผลได้แล้วนะครับหรือว่าถ้าจำเป็นจริงๆทำในระหว่างที่มีแผลก็ได้แต่ว่าจะต้อง control เรื่องของการใส่ internal fixator นะครับก็ต้องมีการให้ยา antibiotic เพื่อเป็นการป้องกันการ reject ตัว internal fixator นะครับแล้วก็ถ้ามี osteomyelitis ก็ต้องรักษาตัว osteomyelitis ให้ได้ก่อนนะครับแล้วก็ส่วนใหญ่ถ้าไม่มีแผลก็จะ prefer เป็น stage สุดท้ายของ Eichenholz นะครับก็คือ consolidation แล้วเรียบร้อยfixation ที่ใช้ส่วนใหญ่จะเป็น3ตัวใหญ่นะครับก็คือเป็น plate screw เป็น IM nail internal medullary nail นะครับแล้วก็อันสุดท้ายก็จะเป็น external fixator นะครับหรือว่าอาจจะใช้เป็น conjunction ใช้ด้วยกันก็ได้เป็น internal fixator กับS-fix หรือว่าเป็นตัว IM nail กับ S-fix นะครับแล้วก็สำหรับconjunctive procedure นะครับต้องดูด้วยว่ามี Achilles tendon tight ไหมเพราะว่าถ้าเราไปทำ construction เราไม่ได้ address ตัว Achilles tendon ที่มัน tight อยู่ก็จะทำให้ความผิดรูปของเท้ากลับมาได้อีกนะครับแล้วก็เรื่องของการดูคุณภาพของกระดูกนะครับบางครั้งอาจจะมีการสูญเสียกระดูกบางส่วนไปอย่างเช่นเคสที่เป็นตัวอย่างนะครับที่ตัวทารัสไม่สามารถเอามาใช้ได้แล้วหรือว่ามี procedure อื่นเช่นการใส่ข้อเทียมที่ข้อเท้านะครับกระดูกหายไปหมดแล้วก็ต้องใส่ตัว spacer เข้าไปหรือว่าใส่เป็น cement antibiotic spacer นะครับเพื่อให้เท้าบริเวณนั้นไม่มีการติดเชื้อก่อนแล้วก็อาจจะใช้เป็น allograft ที่เอามาจากกระดูกฟีเมอร์นะครับถ้าเราใช้เป็น allograft femoral head นะครับก็ต้องมีการทำ flap เป็น muscle flap เคสที่เราทำนะครับก็คือการใช้ตัว flexor hallucis longus นะครับrotate เพื่อไปเกาะที่ตัว allograft เพราะไม่งั้นถ้าเราใส่ตัว allograft เข้าไปอย่างเดียวกระดูกก็จะตายนะครับก็จะทำให้ร่างกาย reject ไอตัวกระดูกนั้นแล้วทำให้ตัว ankle fusion แย่ลงนะครับแล้วก็external fixation ก็ต้องใช้ระยะเวลานานนะครับแล้วก็ต้องมีการ control การติดเชื้อจากพินที่เราใส่เข้าไปด้วยนะครับแล้วก็สุดท้ายนะครับที่สรุปทั้งหมดเลยก็คือควรจะเริ่มจากการทำ conservative treatment ก่อนถ้ามัน fail ค่อยมาเป็น reconstruction แล้วก็ค่อยมาดูอีกทีว่ารายละเอียดแต่ละอย่างเป็นยังไงนะครับก็ขอเป็นตัวแทนนะครับขอบคุณทุกคนกับทางดร. McWilliam นะครับThank you so much for your time here and we really appreciate your times and your knowledge that you give it to us.
Are there any questions?
มีคำถามอะไรไหมครับ